Welcome to the Pituitary Network Association's webinar presentation with Dr. Adriana Ioachimescu. Our presentation will begin shortly at the top of the hour. Before we begin, I know that we have a few people that are just joining us. My name is Linda Rio. I'm the Director of Professional and Public Education for the PNA. I want to let those of you who've logged in early to know a little bit about our whole series of webinar programs, all of which take a tremendous amount of time and effort by a whole team of people here at the PNA in order for these valuable presentations to become available to the public. I especially want to acknowledge Tammy Mazzella for her technical expertise, which makes all of this happen magically. All of our presenters have most generously volunteered their time, which is, of course, more than the hour of broadcast time today. Our presenters have amazing credentials and are folks most of us would never have the chance to just listen to and then be able to actually ask them specific questions. What an opportunity. And remember, you can type in questions today and get a response, time permitting. When it isn't possible to actually attend the PNA webinars live, you can, if you're a PNA member, view any of the prior programs which are available as a member benefit through the PNA's website library located on our website, www.pituitary.org. Being able to access our now extensive library of webinar presentations is a valuable member benefit, along with many other membership benefits. Our newest website, www.pituitarybooks.com, is a site where you can easily purchase books, t-shirts, hats, all conveniently located in one place and specific to issues surrounding pituitary and other neuroendocrine disorders. Hot off the press, you'll also find located there Pituitary Disorders, Diagnosis and Management, just published in May. This is a book written for physicians and others by a host of top experts in the field with up-to-date information. This is a great book for patients to recommend to their primary care physicians, dentists, and other healthcare providers. The PNA also produces brochures that help educate many about the various pituitary and endocrine disorders. We host and co-host with many of some of the amazing medical centers live educational programs as well, such as the all-day conference that's coming up in November for physicians in conjunction with Cornell University. We also have a discussion board available for members, and of course our monthly online newsletter highlights, which provides so much valuable and up-to-date information. There is so much more. I won't go into greater details, but keep in mind the PNA has no government funding. We operate mostly from generous gifts and grants obtained and, of course, membership fees. I want to thank you for being here today. I am also certain you will benefit greatly from the information that's provided here that will begin shortly. I also just want to let you all know that Dr. Ioachimescu is with Emory University, and on Saturday, September 21st, from 9 to 12, Emory is going to have a Pituitary Education Day. The Pituitary Center at Emory is going to have an all-day opportunity for patients and families and friends to learn from experts and connect with fellow patients. So for those of you in the Atlanta area or the greater Atlanta area, hopefully you can make use of that and be able to get further information at www.neurosurgery.emory.edu/pituitary, all in caps. I always get those forwards and backs mixed up. All right, everyone, we will begin in just a few minutes. Hello to everyone. My name is Linda Rio. I'm the Director of Public and Professional Education for the Pituitary Network Association, and we are here to present today another of our webinars in our series. I would like to introduce Dr. Adriana Ioachimescu, MD, PhD, and give her a very brief introduction, which will not in any way provide her due discourse, but we want to get on with the program. Dr. Ioachimescu graduated from Carol de Villa University of Medicine in Bucharest, Romania. She did her postgraduate training in Europe in internal medicine and endocrinology, metabolism, and diabetes. She earned also a PhD in neuroendocrinology from the same university. She completed additional training in internal medicine and endocrinology at Yale University and the Cleveland Clinic within here in the United States. Dr. Ioachimescu is Associate Professor of Medicine and Neurological Surgery at Emory University in Atlanta, Georgia. Her work currently focuses on diagnosis and endocrine management of pituitary diseases. She's co-director of the Emory Neuroendocrine Pituitary Center, a premier tertiary center for neuroendocrine care for patients with pituitary tumors. She has authored many multiple research articles and chapters in the fields of pituitary disease, adrenal tumors, metabolism, thyroid, and bone disorders. I'd also like to thank her in addition to most generously co-authoring with Dr. Tina Constantine and contributing a chapter to my book, which is coming out, her chapter is entitled Specific Endocrine and Neuroendocrine Disorders, Physical, Emotional, Cognitive, and Relationship Aspects. My book, which will come out in early 2014, is entitled The Hormone Factor in Mental Health, Bridging the Mind-Body Gap. Dr. Ioachimescu's current research has focused on pituitary tumors, pathologies, and outcomes with the purpose of validation of prognostic markers and development of novel therapies for patients with neuroendocrine disorders. Without further ado, I would like to, it will be a short break as we switch presenters, but I would like to welcome and thank Dr. Adriana Ioachimescu.
Do I need to? Linda, can we start?
You are up and ready, Dr. Ioachimescu. You can start at any time.
Okay, wonderful. And you can see my screen, correct? Okay.
Yes, we can see it.
Welcome.
Yes.
Wonderful. Welcome everybody to the PNA webinar. And first I would like to thank Linda. This is another wonderful activity she and I are working on together. She is amazing. And also to Tammy, who helped me over the past few days to become comfortable with the webinar system. Our presentation today is about pituitary hormone replacement in women. And I do work for Emory University, as Linda told you before. And thank you for the wonderful presentation. Here's what we're going to talk about. First, couple of pieces of information about the importance of pituitary hormones in women. Then, what are the main causes that would lead to pituitary hormone deficiencies, also called hypopituitarism. In the third place, we're going to talk about how hypopituitarism manifests in women, the signs and symptoms. Then what do your doctors do in order to be able to diagnose this condition? And what are the factors that would prompt the physician to treat this problem? And finally, the goals and risks of pituitary hormone replacement in women. The pituitary gland is the master gland of the body. It is a very small gland, pea-size at the skull base. It is close to another important structure called the hypothalamus. The reason why it is the master gland of the body is that it does produce or stores a lot of hormones that have crucial importance in our life. First, some anatomy. There is an anterior pituitary lobe and then a posterior pituitary lobe. And the connection between the hypothalamus, which produces regulatory hormones for the pituitary, and the pituitary is the stalk. The stalk is the structure made of vessels and neurons, nervous cells. We're not going to talk too much about the posterior pituitary today. It makes two important hormones, oxytocin, which helps with child delivery and lactation, and ADH, antidiuretic hormones or vasopressin, which help us produce urine that is concentrated. We are going to talk about anterior pituitary function. We're going to talk about hormones like TSH, which tells the thyroid gland what to do. Thyroid, of course, has a very important role in development from embryonic life through childhood, and then in adults has an important role in metabolism regulation. ACTH is a pituitary hormone that tells a portion of the adrenal gland how to secrete cortisol. Adrenal glands are situated on top of each kidney. Cortisol is probably the most important hormone if I was to choose one from all the hormones we test every day. FSH and LH, also called gonadotropes, tell the ovaries what to do. Ovaries, of course, are involved in fertility and regulation of the periods, and whenever the ovaries go to rest, when the woman goes through the change of life, that's called menopause. So all this complex ovarian function is in fact controlled by the pituitary gland. Growth hormone. This is something that we all need in order to become tall, but then there are roles for growth hormone in adults as well, and there are receptors for growth hormone in the entire body. Prolactin helps the women breastfeed. Prolactin is the only hormone of those that we've already spoke about that is subject to an inhibitory regulation from the hypothalamus. In other words, when the stalk that connects the hypothalamus to the pituitary is in any way disturbed, the regulation will mean that some of these hormones may be low, while prolactin can be a little high, and that might be puzzling until one understands the different regulation of these hormones. Here's another scheme of how important the pituitary gland is. And we now have here the hormones made by each target gland. The target glands are the glands that pituitary tells what to do. Adrenals, testicles in men, ovaries in women. Ovaries produce, of course, estrogen and progesterone. And growth hormone acts at the liver level to produce something called IGF-1, which is important for physicians because they can measure and rely on this as a function of growth hormone activity. The thyroid gland, situated at the in the lower part of the neck, produces a combination of thyroid hormones T3 and T4. So what would be the causes of pituitary hormone deficiency, also called hypopituitarism? By far the most common is that related to a mass, either a solid tumor or a cyst that is growing in that region. It could be a pituitary tumor if it's formed, if it arises from pituitary cells, or it could be a craniopharyngioma, which is a mass that is that results from residual of the pituitary, which results from migration of the pituitary gland and growth of that residual. So most of the time when these masses produce hypopituitarism or pituitary hormone deficiencies, they are large. Large means macro, macroadenomas. Also, treatment for these masses, either surgery or radiation, can cause pituitary hormone deficiencies. If the deficiency occurs in childhood or during teenage years, the problem might be a congenital malformation of the pituitary gland, and sometimes multiple members of the same family deal with the same problem. It's rare, but I've seen these cases of infection or inflammation causing pituitary hormone deficiency. Probably the most common I've encountered is sarcoidosis, which is a multi-system disease. Trauma can cause pituitary hormone deficiencies. This is rare. It's usually significant traumatic brain injury with skull-base fractures. And finally, anticella, which means that a pouch of cerebrospinal fluid has descended in the cella and is squishing the pituitary gland, which sometimes, not often, but sometimes can become deficient in production of some of its hormones. So talking about the main cause, pituitary tumors, main cause of deficiencies, there are some that are small, like the little round dark problem here within a completely normal pituitary gland, normal in size. This is called a microadenoma. Its size is less than 1 centimeter. This kind of MRI is encountered often, and we see these patients with incidentally detected microadenomas all the time. They undergo imaging for a different problem, and they are found with this problem, with this microadenoma. 1 in 10 people can have these on the MRI. These rarely cause pituitary hormone deficits. Of course, there are exceptions to the rule. If this was a prolactin secreting tumor, too much prolactin would block the woman's ovaries. If this was a ACTH secreting tumor, or Cushing's disease, too much cortisol would block block the woman's ovaries from too much cortisol. The main situation we deal with when we see patients with pituitary hormone deficiencies is a fairly large tumor. That's why it's called macroadenoma, greater than 1 centimeter. You can see it here, and it does come close to the optic nerve, so it's probably causing this person headaches, and this person has risk for vision loss. It's much less frequent than the microadenoma, 1 in 600, but such problems are frequently associated with pituitary hormone deficits. I would like to go through 2 causes of pituitary hormone deficiencies that are unique to women, and they both occur after childbirth. There is a reason for this, and the reason is, of course, the way the woman's pituitary is set up with cells called lactotrophs that are designed to help the woman breastfeed once the pregnancy is completed. Because of this, the pituitary gland actually doubles its size during pregnancy. So the pituitary gland is larger and is more susceptible to dysfunction after childbirth. One of the dysfunction we see after childbirth is called lymphocytic hypophysitis. It's an autoimmune problem, and as an endocrinologist, I see other glands that can get a little bit upset, inflamed after pregnancy. For example, lymphocytic thyroiditis is has a very similar mechanism as the hypophysitis. So how do women with lymphocytic hypophysitis present? It can be a very abrupt, unpleasant presentation with headaches and vision loss. I already told you that the gland was twice the size of twice its size before pregnancy, and now it's even larger because there is inflammation going on. So women can have headaches and vision loss. Just like if there was a big tumor that all of a sudden came into play. They also do present often either with low adrenal hormones or low thyroid hormones, and that is an effect of insufficient pituitary hormone secretion, as well as with diabetes insipidus dominated by excessive thirst and urination. Imaging shows pituitary gland enlargement that sometimes is very hard to distinguish from a tumor, from a macroadenoma. Some women improve spontaneously and even recover the pituitary function. In others, though, this is not the case, and then it is our job to replace the hormones that are missing as a result of persistent inflammation, or to administer high-dose glucocorticoids if the severe headaches and vision loss continue, because it will help the pituitary gland size become smaller, and then the headaches and the vision will improve. How about Sheehan syndrome? Also occurring after childbirth, only from a different problem. It is ischemia, which pretty much means decreased blood flow. It only happens in those women who bleed excessively during delivery. We rarely see these cases today because the obstetrical care improved significantly. But if we were to see a case, the woman could become sick immediately after delivery. Her blood pressure would bottom out. She would feel really nauseated, maybe vomit. She would be very tired, and she would make no milk. It also can be a less acute presentation with failure to produce milk and failure to resume the periods or menses. Imaging shows a small pituitary gland, and treatment consists of hormone replacement. I see these women who are now in their 40s or 50s who were otherwise healthy up until they had this last baby. They weren't able to breastfeed the baby, and they weren't able to become pregnant again. And they may or may not have sought help for the lack of periods. But they were not the same person afterwards. They had fatigue, trouble keeping the weight down, trouble with maintaining temperature regulation, and we diagnosed them 10, 20, 30 years after the fact, and they were deficient ever since that child was born. How about women who have not just had a baby? What are the symptoms of hypopituitarism in other women who may have a tumor or the other causes that I mentioned before? ACTH, or adrenal corticotrophic hormone, leads to cortisol secretion from the adrenal gland. So a deficit of this hormone is called central adrenal insufficiency, because it's not a problem of the adrenal glands, it's just a problem with the way the adrenal glands are regulated by the pituitary gland. Patients present with poor appetite, nausea, vomiting, unintentional weight loss. They feel tired and weak. They feel ready to faint when they stand up abruptly, especially from lying down. They have body aches. Sometimes blood work will show low blood sugar, or in the office the patient will have blood pressure on the low side. But many times these patients may not be diagnosed until they go through a phase of acute illness, maybe the flu, or they go through severe stress. They went to Florida and ran a marathon that put their body on the edge, and cortisol is, of course, the hormone that helps us adjust with any type of stress. So they become acutely ill with vascular collapse, nausea, abdominal pain, and if not treated in time, these situations of adrenal crisis are potentially fatal. TSH, or thyroid stimulating hormone, its deficit will cause central thyroid insufficiency. It's not the Hashimoto or the low thyroid that women get often in their 40s or 50s or 60s. It's not this. The thyroid is healthy. It's just not picking up enough stimulation from the pituitary gland. Women present with non-specific symptoms that may go on for years: fatigue, weakness, cold intolerance, weight gain, facial puffiness. Also, they may have dry skin, constipation, heavy or painful periods. They will start to develop memory loss and depression. The exam will show that they have a slow heart rate and sluggish deep temporal reflexes, and the blood work may show anemia. How about growth hormone? Of course, if there is a growth hormone deficit during childhood, they will end up being shorter than their family or their colleagues, and they may be a little overweight. However, if the growth hormone deficiency starts in adulthood, then we've already reached our final height. So that's no longer the problem. However, my patients with significant growth hormone deficiency can tell that their exercise tolerance is less, they have less powerful muscles and even less muscle bulk. They have more fat instead. Their bones are less strong if we were to do a bone mineral density. Also, there are some subtle changes, but enough to worry some people with depressed moods, social withdrawal, decreased memory, and blood work will show elevated cholesterol. Finally, the gonadotroph deficit, LH and FSH. They would cause central ovarian insufficiency. The symptoms are similar to the symptoms of menopause: decreased libido, vaginal dryness, irregular or absent menses, hot flashes, inability to sleep. Of course, each one of us is different. Some may get the hot flashes worse than others. Mood swings, irritability, decreased bone strength, decreased breast size. When the doctor sees a patient who fits the bill, there are some problems there with the patient health that may point towards a pituitary gland dysfunction, like a tumor or radiation or sarcoidosis, and the patient comes with symptoms that I mentioned before, then some tests are needed to confirm the diagnosis, and then a discussion is needed in order to decide whether replacement treatment is in the cards. The diagnosis of ACTH or cortisol deficiency is made by checking the cortisol in the early morning when it's at its highest, and confirmation comes from a stimulation test either with cosintropin or with insulin. ACTH level can be checked in the blood, and we find it low or normal. This is unlike the adrenal primary problem where the ACTH level would be elevated. So ACTH points towards where the problem is. Please keep in mind that patients who have both low cortisol or low normal ACTH may have a different problem that has nothing to do with the health of the pituitary gland. This situation is very common in the practice of all endocrinologists or health practitioners. It has to do with administration of steroids, either repeated injections, either intramuscular or intraarticular, or multiple courses of steroids like prednisone for different inflammatory diseases, even taking suppositories or putting on creams or lotions that sometimes are over the counter every day may cause an abnormal lab panel with low ACTH and low cortisol. Even cases of daily inhaled steroids were described where the cortisol and ACTH level became low. This is one of the cases that I see often in my office. Women who come to me because they have Cushing-like symptoms. They are gaining weight. They complain of easy bruising. If they were a well-controlled diabetic, all of a sudden they're no longer in good control. Their glucose is elevated. Someone is checking labs and finds that both serum cortisol and ACTH are lower than normal. And then the woman is puzzled because the same doctor who was suspecting Cushing syndrome is now prescribing hydrocortisone replacement, meaning to give her more steroids. So they come to us for a second opinion, and I'm glad they do. The only thing in the history that may have missed the first time around was that this woman already had a lot of steroid in her system. She had had multiple injections of steroids in both hips and back. These effects last for a few months, and the more injections a patient is going to get, the more likely the axis of hypothalamus, pituitary, and adrenal would be suppressed. Arrows points to all the places where steroids administered in any way over repeated courses can inhibit the function of hypothalamus, which instead releases less CRH, which instead tells the pituitary to release less ACTH, which in turn leads to a low cortisol secretion from the adrenal gland. So what is puzzling initially, it actually makes a lot of sense. There are already a lot of steroids around in this woman's body. She is already showing the clinical signs of too much cortisol, but the labs show the fact that the hypothalamus, pituitary, and adrenal glands are actually smarter than the doctors. They've downgraded their production to make no more because there are already enough steroids in the system. Avoiding steroids usually results in normalization of the labs, but it may take a few months, and the woman has to work closely with the endocrinologist to decide whether some sort of replacement is needed at any point until the axis recovers. How about central thyroid hormone deficiency? We diagnose this by measuring T4 level, or thyroxine. And in 100% of cases, it is low. There is no case of central thyroid hormone deficiency with normal T4. Only 75% of patients will have a low T3 because our body has the capacity to make T3 from T4. So even if we make less T4, if our thyroid is already affected by the disease, then our kidneys and liver and other tissues pick up the bill and will push the T3 secretion. T3 is our active hormone. The main thing is that the TSH is actually not elevated. It's inappropriately low. In fact, it's usually normal. Less frequently is slightly low or slightly elevated. It should be elevated way above normal if this was primary thyroid disease like Hashimoto. And keep in mind, internists and all physicians are much more used with primary thyroid disease, which is more common than pituitary disease. So if you're just checking TSH and the patient has all signs and symptoms of hypothyroidism and the TSH is normal, the next thing that should be done is checking T4 and T3, and this might give the answer. But internists are not used to doing this because they are dealing with the thyroid pathology, which is very well put into light by just TSH. How about ovarian deficiency? In a woman who is no longer having her periods, a low estradiol level and low or low normal FSH and LH would fit the bill. Moving on to the goals and risks of pituitary hormone replacement in women, we would like to improve the patient's health and minimize the side effects. We are aware that we cannot fully reconstitute the physiology, but we want to be as close as possible to the patient's normal hormonal function. To me, the key words here are replacement. I am not going to give someone exaggerated doses of any hormones to boost different things like energy or libido or have them lose weight or anything like that. I would like to replace what's missing, and I would like to use physiologic doses because we're walking that thin line of giving enough versus giving too much. And when we give too much, then it's when problems come along. And they might not come along next week or next month, but they will certainly come along in few years, and then we will not be able to undo what's done. I would like to start by saying that any patient who has cortisol or thyroid deficiency, which has been proven, needs these supplements, regardless the age, regardless the symptoms. Some of us can be very symptomatic. Others, we can have fewer symptoms than what the book says. Cortisol and thyroid replacements are essential for life. This is not one of those prescriptions that you want to forget at home when you go traveling for 3 months and so forth. Estrogen replacement is controversial, but is usually recommended in young women in absence of contraindications. And what I'm saying today is based on the literature that is available today. And another webinar in 1 or 3 or 5 years hopefully will settle some of this controversy that surrounds the issue of estrogen replacement. Growth hormone replacement in adults is elective, and we're going to talk about situations when this is needed and how it's done safely. I'm starting with the cortisol because this one, as I said already, is essential for life. It's a very important hormone. Replacement, at least in my practice, is done with hydrocortisone, which is has the exact same molecule. So it is a bioidentical synthetic preparation. And usually I start by calculating the need of how much cortisol that person needs based on something called body surface area. Hydrocortisone will not last 24 hours. Most of my patients require 2 doses. A higher dose first thing in the morning when the cortisol is supposed to be at its highest level, and the smaller dose around 3 or 4 p.m. I have patients who like to take 3 times the medication 3 times a day just to make sure that they are covered during the day. And that's fine as well, but the morning dose should be higher. There are other options. Prednisone and dexamethasone are administered in 1 morning daily dose. And this is convenient, of course. However, in my view, there are concerns with almost any dose of prednisone with regards to bone mineral density and risk of osteoporosis. So I prefer the hydrocortisone, which is the same molecule that our body makes synthetic. There is an acute illness instruction that my patients always take with them. They have to increase the dose 3 times for 3 days if they get the flu or any other acute illness. Once we met and we started the treatment, we don't just stop seeing each other. We need to see each other again and adjust the dose if needed. Dose may be decreased if the patient experiences insomnia, lower back pain, weight gain, and increased appetite, increased acne, too much facial hair, easy bruising, or glucose gets out of control. Please keep in mind long-term therapy with higher than physiologic doses may lead to increased risk for fracture, cardiovascular disease, and diabetes. On the contrary, the dose may need to be increased if the patient continues to have symptoms of adrenal insufficiency with fatigue, poor appetite, weight loss, muscle pain, decreased glucose. Also, those patients who take hydrocortisone, once we start them on growth hormone replacement, we usually need to increase the hydrocortisone dose. We can do blood and urine tests to figure out how much hydrocortisone is needed, not when patients are taking prednisone or dexamethasone. One myth about cortisol replacement is that it is making patients gain weight. This should not be the case if a physiologic dose is used. However, if the patient lost a lot of weight when sick with cortisol deficiency, we expect the replacement treatment to restore the previous healthy body weight, and our healthy body weight is different. Patients treated with high-dose steroids for asthma, arthritis, they may gain weight and develop signs of Cushing's because we're talking about powerful steroids in different doses. And also, the weight gain may occur if inadvertently a higher than physiologic dose is used. So follow-up visits are important. Stress doses of glucocorticosteroids when intense exercise is carried on for any fever or acute infection, but if you have to decrease the dose on your own. However, for recurring vomiting or diarrhea, patients should go to the emergency room for intravenous hydrocortisone administration and for hydration. Whatever procedures are planned, the anesthesia person needs to talk to the endocrinologist about stress dose steroids perioperatively. If a patient is taking hydrocortisone and is getting ready to deliver a child, she needs hydrocortisone intravenously. And at all times, patients with adrenal insufficiency should wear a medical alert bracelet and identification card. How about low thyroid treatment? We usually use levothyroxine, which is a synthetic T4. Remember how the thyroid gland makes T4 and T3, so it's thyroxine. This is what I prefer. This is what most endocrinologists prefer. It is given as one dose on an empty stomach. However, there are other options. There is a combination of T4 and T3. Remember the other hormone that is made by the thyroid called T3. And the T3 can come as a synthetic compound or from natural desiccated thyroid. We recommend this combination for patients with persistent symptoms of hypothyroidism despite replacement with T4, with levothyroxine, especially if the T3 level remains low. We only start treatment with thyroid hormones if the adrenal insufficiency was ruled out. Otherwise, it would put the patient at risk for adrenal crisis. We tell the patient to avoid taking calcium multivitamin iron along with a thyroid pill because it will not absorb. We start with smaller doses in elderly patients or those with heart disease because too much thyroid hormone can make your heart beat too fast and then put you at risk for a cardiovascular event. We like to monitor with free T4 and free T3 levels, not TSH, and this is one of the main mistakes that patients and their doctors get entangled into, because you have the endocrinologist prescribing it and someone else adjusting the dose and someone else will just go by a low TSH level, when in fact TSH is the problem there and free T4 should be and T3 should be used to monitor treatment. There is no need for frequent labs. You need to give it time for the system to reset itself. Labs should be done 6 to 8 weeks after starting treatment and then yearly. But some adjustment of the dose might be necessary if growth hormone or estrogen is started. Also, if the patient loses or gains more than 10 pounds, or if the patient changes the brand. So the insurance was covering one brand of levothyroxine, now is changing its cover and it's going to cover for another. Even though the same dose is written on that prescription, they might not be bioequivalent. Do tell your doctor he's going to recheck your test to make sure slight adjustments are not needed. During pregnancy, we usually increase the dose once pregnancy is confirmed by 25%, and then we measure the levels monthly afterwards. There is a myth about thyroid treatment and weight. I need my dose increased because I have not lost enough weight. In fact, higher than physiologic doses of thyroid supplement of any kind, natural or synthetic, will make you lose weight. You just need to take enough. But that is not how we replace hormones. That would be wrong. Too much thyroid hormones would lead to tachycardia, the heart beating too fast, and even a dangerous heart rate problem called atrial fibrillation. In the long run, the bones will suffer and there will be increased risk of fractures. The other myth is about natural thyroid supplement being better than synthetic. And there's a lot of controversy here, and I do admit there is room for additional research, and I wish there were more publications in this field so we can clarify this controversial topic better. Here is what we know about desiccated thyroid. It's derived from animal thyroid, in particular from pigs, and it contains both T4 and T3 in a ratio that is different than in humans. In fact, the T3 amount that desiccated thyroid has is 4 times greater than what a normal thyroid gland would produce. So there's a difference to start with, and again, here's a contrast with what I told you initially, that we're trying to replace and recreate physiology. And this is why we hesitate to prescribe desiccated thyroid, because we know that it has too much T3 in it. Also, any patient, even those with pituitary dysfunction, unless they're acutely in the hospital, are usually capable of producing their own T3 in the liver, kidney, and other organs. It's a more physiologic way to produce your active thyroid hormone T3. Taking T3 may cause symptoms of too high or thyroid hormones, like if you had too many cups of coffee one morning and you start having palpitations, shaking, and you feel a little more anxious and agitated. And I've seen this happening with my patients taking desiccated thyroid. Also, you have to take it a couple of times a day, which it may not be as convenient. Moving on to the postmenopausal hormone replacement with ovarian hormones. This is the same issue as the issue of menopause, and it has and pituitary patients should be treated as any postmenopausal hormone in regards to ovarian function replacement. What we know today is that the combination of estrogen and progestin is associated with both benefits and harms. The clear benefits from HRT are increased bone mineral density and decreased risk for fracture, also a decrease in the risk for colorectal cancer. There are potential harms, and they came from 2 big studies, WHI and HERS. And there is a clear risk of increased breast cancer with long-term therapy by 26%, increased risk for coronary artery disease by 29%, stroke by 20%, venous thromboembolism, clotting, by 100% within the first 1 to 2 years of therapy. There might be a significant increased risk for cholecystitis by 50%. So this applies to women who are older than 51, who would like to prolong the time when they have enough estrogen and progesterone. Unopposed estrogen without progestin did not increase the risk of breast cancer after 5 years of therapy in these studies. However, if a woman still has a uterus, she needs the progesterone, because otherwise she's at risk for endometrial cancer. So current guidelines for postmenopausal women state use the lowest estrogen effective dose to relieve symptoms for the shortest possible time, individualized based on patient's symptoms and other health problems. But keep in mind, these studies showed equine estrogen and synthetic medroxyprogesterone combination. So ongoing research should show if a different combination may have a different, hopefully better adverse profile. How about before menopause age? So some of the patients I see with pituitary disease are actually young, and they are younger than 51, which is the average age of menopause in the United States. So menopause earlier than 45 is associated with increased cardiovascular diseases, problems with cognition, dementia, increased risk of anxiety, depression, sensitivity, definitely increased risk for fractures and osteoporosis. Overall, not feeling well, decreased physical functioning, more pain, and finally increased mortality. And the worst problems occur in women who lost their ovarian function early. Now, most of these problems are improved by HRT. So the worrisome WHI findings that I just went over in postmenopausal women do not apply to the young woman with pituitary disease. So we think that estrogen plus progesterone, if uterus is present, should be continued until age 51 in absence of contraindications. One word about bioidentical HRT. Since 2002, when everybody started to be scared about WHI results and synthetic estrogen and progesterone, women sought alternatives to FDA-approved HRT, including compounded bioidentical HRT. Here's the definition of bioidentical. Have the exact same chemical and molecular structure as hormones that are produced in the body. So bioidentical does not mean natural, it means the same structure. How about compounded? It defines the combining or altering of ingredients by a pharmacist in response to practitioner's prescription to produce a drug tailored to the individual medical needs. Here are the bioidentical FDA-approved HRT, so please don't be confused about the terms. There is bioidentical Food and Drug Administration approved hormone out there, which is synthetic, that 17-beta-estradiol, which can be given orally or transdermal, which I prefer because it doesn't affect the liver, or progesterone, which can be given orally for 7 to 10 days per month to protect the uterus. Estrogens in human body are 17-beta-estradiol, estrone, and estriol. Estriol is the least active, and it's found in the smallest concentration in the healthy woman's body. Compounded bioidentical non-FDA approved HRT are rich in estriol. If you can see the ratio there, estriol to estrone to estradiol or estriol alone preparation, these are weak and they have never actually been associated with improvement in the outcomes that we're all looking for. Pellets result in very high estrogen levels and associate severe hot flashes on treatment stop. Definitely not something that I would recommend. Topical progesterone as a non-FDA approved HRT has not been shown to have sufficient activity to prevent the endometrium. So be careful here if you have a uterus, start taking estrogen, and the progesterone is not by mouth, it may not do enough to protect you. So one myth about compounded bioidentical HRT is that it's safer than FDA-approved HRT because it is natural. However, all these preparations compounded will not come in various dosages and they have not been tested one against each other. FDA requires a more rigorous safety and efficacy studies than compounded do not require such thing. Chemical reactions are still required to produce compounding HRT, so we're not really talking about a fully natural product here. And most importantly, there are no studies that show that compounded HRT is associated with less risk of breast cancer. Better effect on bones is another myth. In fact, compounded HRT has never been shown in any published study to prevent bone loss or fractures. And those salivary testing that some practitioners do to provide personalized therapy, actually they have never been studied enough and could be potentially misleading. And they vary, the measurements daily depending on the time of the day, diet, salivary flow, and I would not use them to guide therapy. I would use the way the woman feels. So when to use compounded HRT? When FDA-approved HRT is not tolerated or does not bring enough benefit to the woman after a thorough discussion between the patient and the doctor. Regular pap smears, gynecologic exam, breast exam, mammogram, periodic lipid panels are required regardless what kind of HRTs they are, compounded or FDA approved. Growth hormone therapy in adults is a controversial issue. It is associated with many benefits on the muscle and bone front and some benefits on the lipid front, but there is no data regarding cardiovascular events, mortality, or fractures. It does come with risk of swelling, joint pain, carpal tunnel, worsening diabetes, worsening sleep apnea, headaches. There is no data supporting that growth hormone would make one get more cancer, but it is contraindicated in patients with active malignancies. Growth hormone replacement is recommended for those adults with significant symptoms and unequivocal biochemical evidence of growth hormone deficiency. Those can be adjusted. Women usually need higher doses than men, especially if they take estrogen at the same time. IGF-1 is the parameter measured to keep it to make sure the dose is appropriate. And most patients improve the way they feel, mood, cognition, exercise tolerance in 6 months. If not, there is no need to continue the treatment because this is not a life-saving treatment. But it can nevertheless improve the quality of life in many of these folks. Follow-up visits are important. MRI of the pituitary is needed if the patient is known with a pituitary mass, bone mineral density, lipid panels, check glucose tightly, quality of life questionnaires, free T4 levels, adrenal levels. Everything is needed during growth hormone replacement. You want an endocrinologist to do that. Instead of conclusions, long-standing hypopituitarism from tumors or radiations usually involve growth hormone and ovarian insufficiency, but TSH and ACTH may also occur later in the course. ACTH deficiency may be uncovered during acute illness. Adrenal and thyroid function are essential for life. Estrogen, progesterone, and growth hormone replacement are elective, but may improve the quality of life and other health issues. So patients and physicians should sit down and talk about it, so therapy is individualized. And most importantly, lifelong endocrine follow-up is needed in patients with hypopituitarism. Thank you very much, and if there are questions, I'll be glad to take them.
Thank you so very much, Dr. Ioachimescu. Fascinating information. We have a large number of people and quite a few questions, so I'm going to try to get to those right away. We have a woman who is postmenopausal, diagnosed with central hypothyroidism after her third pituitary resection for Cushing's. She had taken 100 milligrams of thyroid replacement for 2 years. Her free T4 has now dropped below normal, and noticing many hypothyroid symptoms, but has lost weight. She's read about thyroid-adrenal connection and wondering if this is part of the problem, and what would you recommend in this situation?
I certainly am concerned about the undetectable free T4, and I am concerned about additional deficiencies that may not have been present before. So I would recommend that she visits the endocrinologist for a comprehensive pituitary hormone evaluation, and it will be more clear if higher doses of levothyroxine are needed, or something else is going on here. Maybe the weight loss is from adrenal insufficiency. Definitely not easy to explain without more labs in front of us.
Thank you very much. Obviously a complex issue that we can only kind of guess at. Also want to recommend to everybody that obviously the presentation today is not meant to replace specific discussions with your individual doctors, of course. We have another question from someone who had Lyme disease about 3 years ago. She was using a combi patch for hormone replacement, had a failure of the anterior pituitary, but has had adequate growth hormone. Her MRIs have been normal, and so no obvious reason why it would have failed. She says she has no children, nor have gone through any childbirth. What other treatment is there for women in their 50s in such a case?
So if the question refers specifically to hormone deficits in terms of ovarian function, she should talk to her gynecologist or endocrinologist or primary care physician about symptoms of low estrogen. And the worse these symptoms are, hot flashes, preventing her from sleeping, and so forth. If these symptoms are significant after stopping the patch, the doctor might reconsider starting it. Of course, keep in mind that there are some potential contraindications. So, things like GYN exam and mammograms and breast exam are absolutely mandatory, family history taking and so forth. So it is a possibility after age of 50 for women who are otherwise healthy, who have significant symptoms of low estrogen, to stay on a small dose of estrogen and progesterone if uterus is still there, if everything else is good. So I have a lot of patients who choose to stay on the replacement, but they are very well informed about the potential risks, and they keep up with all the screening tests we recommend. For hot flashes, if estrogen cannot be continued, there are other medicine that are under antidepressant class, but they also have been proven to work in reducing hot flashes and menopause symptoms. Those are pills that can help them feel better, and there are even some blood pressure pills that can be used to reduce hot flashes. So there are several options out there. What needs to happen is an informed discussion with a specialist who is comfortable having this discussion, and a lot of primary care physicians are comfortable. Most gynecologists are very comfortable with having this conversation, and most endocrinologists as well.
Thank you very much. I have a couple questions that I'm going to try to combine here. We have a question from a woman about whether you treat hypopituitary patients, female patients, with testosterone. That would be one question. And she says this is the only thing that restored her libido, but she was also looking for some kind of reference table to see whether her levels are within range. And then kind of going along with this, can hypopit women, due to damage from pituitary surgery with Cushing's, need HRT beyond the age of 51?
Okay, so let's start with the second question because it's easy. Once a woman is 51 years of age, the same precautions and guidelines that apply to healthy postmenopausal women apply to pituitary patients as well. So regardless the reason why ovarian function was lost, once you're 51, you should just go to your gynecologist, and the same precautions should be taken as if it was a menopause issue. I do not have enough data to support a special treatment for pituitary patients in terms of estrogen and progesterone after age 51. The issue of testosterone and replacement, and in general androgen replacement in women, it is even more controversial than the issue of estrogen and progesterone. So far, based on the literature published, and we endocrinologists are a very detail-oriented category of professionals. We want to make sure that we don't just give powerful molecules to people. We want to have the right reasons for doing this. So the issue of testosterone replacement in women is very controversial because there is not enough data associated with a good outcome, not necessarily associated with a bad outcome, but we would need more reasons to do that. However, from all the studies that I've seen, if there is one benefit that showed up in most of these studies was increased libido as a result of increased testosterone. So I understand where our listener is coming from. I think she has to be careful with the doses not to be too high. And it depends what kind of replacement she gets, but generally testosterone can also be measured in the bloodstream, and we wouldn't like it to be elevated above normal range of women who don't have any problems. Too much testosterone may give one more energy and more sexual desire, but it does have its downsides as well, and they are not even fully known because not enough research has been done in women. So this is a chapter that has just opened and is still controversial. So I would say if the woman feels fine and the levels are in physiologic range, keep up with that practitioner, but there is not enough published data to support the long-term consequences of this therapy. And that's one of our main concerns, to make people feel longer, to live longer and better.
Due to our time constraints, we'll just do one more question and then we will need to close. We have a 42-year-old woman who's postmenopausal, and her pituitary has shrunk with medications. She's taking growth hormone. She has lupus with associated joint pain. She wants to know if she should be taking the growth hormone, and she is not taking any other hormones.
I am afraid I don't have enough information to say whether she should or should not take the growth hormone. The decision is based on clinical symptoms that we described before and information that the doctor had when he tested the pituitary gland, you know, the low levels and stimulation tests. But I'm not sure I can answer this particular case. It's too detailed. I understand that there is lupus also going on there, but as far as I can tell on the surface, I cannot see any connection between the pituitary disease, lupus, or growth hormone replacement. But I would follow up with my endocrinologist at least once a year. If I'm taking growth hormone replacement, I would make sure that all my screening tests, age-appropriate, mammogram, pap smear, GYN exam, colonoscopy when time comes, all these things are checked and they are normal. And I would check with my doctor once a year for any type of tumor growth, you know, besides the very frequent basal cell carcinoma of the skin. Any other tumor growth, even of the skin, in context of growth hormone replacement might be a problem. So a yearly visit with a doctor.
Thank you, Doctor. Could you press a key? We want our session has just gone over a little bit. Just need you to press any key to be able to keep the session going. We're going to just be concluded.
How is that working?
There we go. Okay. You're fine. I do want to thank all the participants and all those who sent in questions. Certainly want to thank you, Adriana, for your amazing presentation today, as well as all the things that you contribute to the field. Just absolutely wonderful. Can't thank you enough. I want to remind everyone who's participating here that you can go back and view today's presentation. It will take a day or so before it gets posted live on the Pituitary website, and for a bit of time you can have your friends, your family members to be able to watch this for free, but then after a couple weeks it does become just a member-only benefit, along with the many other webinars that have been presented. If you're a member, you can have access to those, which is an amazing, amazing benefit. And you can also recommend that your doctors, I think doctors, dentists, and others be aware of these webinars, because these are very, very highly packed with a lot of valuable information. I do want to finally let you know that next month, on September 13th, we are going to have Carmina Kilty-McGee, who's a clinical nutritionist, actually someone I know, also a contributor to my upcoming book. And she's going to present on the nutrition-endocrine connection, out of chaos into balance. And I think that should be fascinating from a nutritional standpoint. So I want to thank everyone for participating, thank all of you who sent in questions, and we will see you next month.
Thank you so much for allowing me to be part of this. It was a pleasure and an honor.
Thank you.
Bye.